Hey everyone, thank you for joining and welcome to our discussion with UMass Memorial Health about building a hospital home programme. We have two amazing speakers today, and I'm going to try and do as little talking as possible so you can hear from Candy and Taki. My name is Chris McCann. I'm the CEO and co-founder of a company called Current Health. We help healthcare systems with care in the home, including hospital at home programs. Our two amazing experts today, firstly, Candy, who is the interim associate vice president at UMass Memorial Health's hospital at home program. Candy joined UMass in July of 2021, bringing 40 plus years of nursing and leadership experience to this exciting new program. Prior to joining the hospital at home program, she held various hospital-based leadership roles as the Associate Chief Nursing Officer for Emergency and Psychiatric Services for UMass and the Chief Operating Officer at Marlborough Hospital. Taki is an internal medicine physician by clinical training and practices as a virtual home hospitalist at UMass Memorial Health Hospital Home Program, where he is the medical director and also the faculty for the program in digital medicine at the University of Massachusetts Medical School. Prior to joining UMass, he was the senior medical director in the Medically Home and Atrius Health Hospital at Home program. So with that, I'll maybe hand over to Taki and Candy. And firstly, thank you so much for taking the time to do this today and share all of your expertise and thoughts with everyone.
Great, Chris. Thank you so much. Taki, next slide, please. As Chris said, I'm Candy Symansky, and my colleague, Dr. Michaelides, you'll hear me call him Taki throughout the program. We have had the pleasure of very quickly ramping up a hospital at home program, and we're thrilled to be able to share our experience with you. We really started last, I think officially March to get this program up and running, and we did accept our first patient in early August. So very exciting 6 or 7 months here with our brand new program. Next slide, please, Taki. We hope to just bring you through our journey from early planning through implementation, and then up to date on a few statistics for where we are now in terms of our metrics and some of the things that we're able to measure. I think you'll hear us say a few times we're very early in our program, but we certainly have some metrics set up, and we'll be happy to share that. And then, a little fireside chat with Chris to finish out our program. Next slide, Taki. So just a little bit about UMass Memorial Health. I have actually been with the system since 1981. And as Chris said, in various roles. We are a 7-member system. We've just recently added a new hospital to our system, which is just south of Worcester. So in the city of Worcester, there are 3 campuses. One is an ambulatory surgery campus. The other 2 are acute inpatient hospitals, both with very, very busy emergency departments. And then we have Health Alliance in Clinton to our north, and we've recently added Harrington Hospital, which I said is to our south. We are the UMass Memorial Medical Center, which is where we are licensed out of, is a primary safety net tertiary care academic medical center. We both the Memorial and the University campus, as I indicated, are very, very busy hospitals. And we do provide care to, I think it's actually closer to maybe 60% of all the Medicaid patients in our area. So we really are an incredibly important system to caring for underserved. And that's actually a mission of the system, which we are very proud of. Again, about 2,400 physicians across all specialties. Unfortunately, and as a challenge for us, we actually have the fewest hospital beds per capita in the state. Many years ago, Massachusetts, started to decrease some of their inpatient beds, and we have had a capacity challenge since then. To our advantage, though, and I think something that really helped our program tremendously, we did operate the DCU COVID field hospital for the state during the 2020 surge. We opened that not only once, but twice. So we had some experience in alternative care sites, which I think, in the long run really helped us in terms of setting up our program. Next slide, please, Dr. So our challenge was, of course, we're underbedded in central Massachusetts. It's not unusual for our emergency departments to be holding multiple inpatient admissions. So that, of course, led to the increasing inpatient demand. We all know that we're struggling with the fact that our post-COVID volume is back. We're seeing patients certainly who are quite ill because maybe they've delayed their care during COVID. So it's certainly an incredible challenge for our colleagues on both the university and Memorial campus on a daily basis to find appropriate beds for their inpatients. So once we knew that we were able to set up an alternative care site, that made it a little bit easier, I think, for the system to make a decision to look at what alternatives are out there. And we never want to set up a program that doesn't bring value to the organization as well as to our patients. And we pay particular attention to make sure that we really are delivering a program that serves multiple populations. We continue to grow our geography, which we'll talk a little bit about. But again, we just give incredible care to a variety of patients. It's really quite cool, and I think you'll learn much more about that as we go through. Next slide.
Great. Well, Chris and Candy, it is a privilege to be here with this team today. And again, my name is Taki Michaelides. As Candy and Chris mentioned, I'm an internist and the medical director of the program. Just wanted to share a little bit of a historical view on acute care in the home. And I thought this was a great quote from the World Hospital at Home Congress several years back, which was, in the beginning, everyone who could afford to be was treated at home. Hospitals were places to be avoided. There were high infection rates and high mortality rates. And the truth from our prior existence really is not that different from our truth in our current state. If you can bring the acute level high acuity care to the home, patients just do better, and we'll review some of the data. In the United States in particular, we've had a multi-decade journey with home hospitals, starting in the late 90s with early investigation out of Johns Hopkins University with Bruce Leff. Over the past 10 years or so, we've had an emergence of randomized controlled clinical trial data summarized in meta-analyses with highly favorable data, which we'll discuss in a few minutes, regarding readmission reductions, mortality reductions, safety, and patient satisfaction in particular. But through the early 2000s, 15, 16, 17 years, we still had fairly slow home hospital adoption across the United States, primarily due to struggles with inpatient level reimbursement not occurring for home hospital in the same way that occurred for brick and mortar hospital. We also had the founding of multiple home hospital vendors. And then obviously in 2019, 2020, we saw the emergence of COVID across the United States. As Candy mentioned earlier, in our own UMass journey, we opened the DCU COVID Field Hospital in 2020. And then in terms of major shifts in home hospital emergence, in November 2020, CMS, in really a very brief time, passed the acute hospital care at home waiver to facilitate Medicare fee-for-service as well as Medicaid payments for hospital-based delivery systems delivering home hospital care. And so where we probably had 30 to 40 home hospital programs in the pre-waiver era, we are now north of 180 home hospital programs across the United States, with patients receiving high acuity inpatient level care in the home and doing very, very well. So as Candy mentioned, we launched our program in 2021 in August, and admitted our first patient in the early part of that month. I thought I'd just very briefly review some of the meta-analyses, and what you'll typically find is that the home hospital data is remarkably consistent. When you randomize folks who come into the emergency department who are appropriate candidates for home hospital care, when you randomize those folks to home hospital versus brick and mortar hospitalization, you tend to find 20 to 30% reductions in mortality, 20 to 30% reductions in 30-day readmissions, and then significant, often north of 80% reductions in the risks of those patients being transferred to skilled nursing facilities, short-term rehabs, or long-term care settings. So we're keeping our folks safely in the home for longer. And I think what we'll find in addition to these readmissions and mortality reductions is that you really don't see concerning safety signals. So patients aren't falling more often, they're not becoming more delirious, they're not getting hospital-acquired conditions like infections or DVTs in the hospital. In fact, the data suggests the opposite. Like you might imagine, when you've got an intervention that works and is now recently being reimbursed by Medicare and Medicaid, is that hospital systems and payers embrace the care model. And so like I mentioned earlier, we've now seen leading health systems, including UMass, across the country adopting home hospital, both on the delivery system side and on the payer side. And so I've just highlighted some of the folks who are doing home hospital care, but this is just a small number. There are many, many other folks providing high acuity inpatient level care in a way that is safe, effective, and highly patient satisfaction oriented. Candy, let me turn it back to you to share an early patient journey from our program.
Great, thanks, Taki. And you know, it's interesting to note of those 180 programs, I'm not so sure that any two of them are exactly alike. I think you have to, be very open to constantly PDSAing your program. And that's exactly what we do here every day. What we'd like to say to people is if you were given a choice, where would you like to receive care? So the picture on the left is one of UMass Memorial's hospital home nurses, Lisa, and she's taking care of a patient in his home. This was one of our very first patients. He was a gentleman with a history of lung disease who contracted COVID. Both he and his wife had COVID, and we brought him home and took incredible care of him. And just an amazing journey. For somebody who's been a nurse for a very long time, I think a year ago, if you would have said to me, you can take patients home and take great care of them, I would have maybe rolled my eyes and said, yeah, I'm not so sure about that, but I am telling you, this is just an amazing way to take care of patients. The contrast, of course, is in a very, very busy inpatient hospital. We like to describe ourselves as think of us as a med-surg unit, just out in the community versus in the bricks and mortar hospital. So at home, we have the nice opportunity to be able to spend uninterrupted time with our patients, whereas, as many of you know, in the hospital, it's as much as you want to try to control the chaos, it does get a bit challenging. Next slide, Taki. So again, we like to consider ourselves an inpatient med-surg unit. Our goal, of course, is to provide just the most amazing, safe care to our patients. We'll talk a little bit about some of our early results around satisfaction and feedback, but it's an incredibly safe way to take care of patients. So our patients actually come from either the University of the Memorial campus at this point. We really thought initially that most of our patients might come out of the emergency departments. It turns out that we probably take more off the inpatient units. Right now they have to have an eligible acute medical condition. Some of the typical things that we see are pneumonia, COPD exacerbations, heart failures, of course, complicated UTIs, urosepsis, a fair amount of skin and soft tissue infections, and then course, patients with COVID. And in fact, one of our very first patients actually had COVID and malaria, having just returned from Ghana. So we're seeing some very typical type patients and then some atypical ones as well. But each of our patients require ongoing acute care. And I think that's sometimes a challenge for people to understand the difference between us and perhaps home health. So each and every patient has to be screened by case manager. They have to meet inpatient criteria. We use interqual, and then pass a hospital at home safety screening process that our screeners go through with each and every patient. And we'll talk a little bit about that as we go forward. All of our physicians and nurses are employed by UMass Memorial Health, and they're all very comfortable with acute care. We are still continuing to work on our standard work, which is very important to us, but we start every day at 7:30 in the morning with a daily multidisciplinary rounds. We've gotten pretty efficient at that. It used to take us, 30 minutes to get through 4 or 5 patients. Now we actually can do anywhere from 5 to 8 in less than 30 minutes. It just depends on how many new admissions we've had the day before. But we start every morning at 7:30. Our physician of the day coming on, as well as the one going off, will debrief each and every patient with the team that's here that's going to take care of the patients that day. Every patient gets at least a daily video visit by one of our hospitalists. And that is usually facilitated in the home by the nurse, so that you get the patient, any one of their family members that wants to join, the physician, and the nurse, all on the same video call, so that everybody is on the same page around the goals of care. And then every patient gets at least 2 in-person nurse or MIH paramedic visits during the day. And as I indicated a few minutes ago, those are uninterrupted visits. So it's really quality time spent with the patient. Our patients are monitored 24/7. We have partnered with Current Health to do that, and we'll talk a little bit more about that actually as we go forward. But we're able to see their vital signs 24/7, and then any issues that have come up. You must have 24/7 rapid response capabilities. We do that with our MIH paramedic colleagues. We're very fortunate that the medical center actually has its own emergency ambulance service, and it's an all paramedic service. So there are several paramedics who support something called Medics in Home, which again is a brand new program, but they're linked to our program and in fact work out of our command center during the day. And so they're available 24/7 to do wellness checks or to respond to issues. And of course, we have an excellent 911 capability in this area, which you absolutely need to have. Because of the waiver, you have to be able to respond within 30 minutes. It's pretty impressive what we can bring in homes. I like to say to people, we really can't do MRIs or CTs yet. But other than that, we collect our own lab specimens. We're able to do EKGs. We can bring in ultrasound and X-ray. We've done echoes in the home. We always have oxygen available, IV medications, IV fluids. We can do nebulizer treatments. We've partnered with a durable medical equipment company so that we can bring in, oxygen concentrators, bedside commodes, just anything a patient might need to be able to transition home safely. We really pride ourselves on our multidisciplinary approach to patient care and discharge planning. We've learned a lot about the social determinants of health. So we spend a lot of time on medication reconciliation, just any behavioral or social issues in order to meet our patients' goals of care. So it's really quite fascinating that you can actually move almost everything you can do in the bricks and mortar right into a patient's home. Next slide. You cannot do this program without the ability to be able to monitor your patients 24/7. And as I indicated, we have partnered with Current Health. It has been a great partnership. I think both of us have learned a lot through our early months of our program. So Current Health allows us to place a wireless device on our patient's arm, and then we're able to see those vital signs constantly throughout their inpatient stay with us. There are several ways we can see them. We can see them on a dashboard on our computers. We actually have an app on our phone, and people laugh at me because I check that throughout the day because I have a good sense of where the patients are by monitoring that app. Each patient is assigned a tablet. The coolest thing about that tablet is there's one spot that they can push if they need help 24/7, and that help is readily available to them. And it says, I need help. So it's just an amazing device. Current Health, right now we're using Answer Pro to monitor the patients and to reach out to us if there are any issues with the patient's vital signs, or if the patient indicates that they are ill. And all of that information, and it's a tremendous amount of information, is automatically interfaced into Epic, which is what we use as our electronic health record. It does take some time to get your parameters correct, but I think we're in a pretty good spot right now. But you do have to be a bit patient as you're working through this, and you get to know your patient population a little better. Next slide, Taki. Safety, of course, is paramount to any program, but especially if you're a new program. We did apply for a CMS waiver, and in that waiver, we had to indicate some of the conditions that we would be willing to admit to our program. I will tell you that CMS gives you some leeway there. And as long as you're comfortable that you can safely take care of the patient, we've not had any pushback in terms of the types of patients that we're selecting. Right now, we are up to about 7 to 9 patients on a daily basis, with a goal, of course, to double and triple that in the next few months. Our mean age is around 63 years of age. I actually thought it would be a bit higher, but I think COVID and some of the skin infections have helped to keep that age down just a little bit. 54% of those have been female patients. Right now, we do only accept Medicare and Mass Health. We work every day to try to bring other payers on board. So about 66% of our patients are Medicare and 34% are Mass Health. In terms of admitting diagnosis, you can see on the slide, we've certainly seen, 23% have had severe COVID disease, and we're able to continue their dexamethasone and remdesivir treatment at home. So we've, and as I said, oxygen, skin and soft tissue infections, 7% with COPD, 5% with CHF. And then this conglomerate of others, as you can see, acute pancreatitis, AKI, acute injury, kidney injuries, hyponatremia. Our average length of stay is between 5 and 6 days, probably 8 days, a little over 8 days if you include the brick and mortar hospital. And we, at some point, I'm sure we're going to get some pushback on our length of stay. But our thought is, right now it's the quality of care we're bringing, so that hopefully we'll drive down that readmission rate on the other end. We have had one fall, but no injuries in that fall patient at home. Certainly no collapses, CAUTIs or C. diff. Our patients do have PICC lines and midlines, but again, with 2 visits a day, we keep a very close eye on those lines. We have had some escalations back to the brick and mortar. We're running at about 9, it's just a little over 9%, which is under sort of the national average. But again, it's a metric that we watch very carefully. We also watch where we discharge our patients to. And as you can see, in terms of SNFs, we're at about 1.6%. Many of our patients are discharged with services. We do set those up. We try our best to maintain services that they may have had prior to admission, and then we can add additional services going forward to ensure they have a safe discharge from our program. As I said, we really believe our value is on the readmission end of this, and right now we're running at 4.7% readmission rate, which again is under the national average, but we continue to watch that very carefully. Next slide, Taki. We are constantly looking at where we're headed next. You can see in the picture our team and two of the vehicles that we use to take care of, transport our staff to be able to care for patients. So right now we started with Worcester and the town of Shrewsbury. We have added the town of Holden and Auburn to our service. But we have plans to expand from there. You have to always be able to grow your geographical area, but that takes some alignment with our MIH partners and 911 in the various surrounding towns. So we're looking to expand our service area, our payer partnership. I feel like we're on the phone doing conference calls with different payers on a weekly basis. Our admitting diagnosis, as I said, we look at whether we can safely care for that patient based on their diagnosis and do our best to try and get that patient home. We're working on expanding our admission hours. I'm sure many organizations, their discharge times or their ability to be able to transport patients out of the medical centers are a little bit later in the day. So we're looking at adding an evening shift so that we're able to admit patients. We certainly don't want to be in our patients' home past 11 o'clock at night. But again, it's a PDSA process that we're looking at. As we grow, we'll add additional hospitalists, nurses, add some additional support to our MIH paramedic team, just so that we can meet all the needs of our patients and grow safely.
Awesome. Taki, Candy, thank you so much for such an in-depth walkthrough of your journey. And honestly, as someone looking in from the outside, I think it's been truly incredible to see how quickly you've stood this program up and grown it and got through all of the different challenges that you've had. And to jump into questions, given Taki talked through the evidence of the effectiveness that's out there, and given the benefit you're actually seeing in the field, we are still seeing, I guess, many organizations across the US who are struggling to get the program off the ground, who are maybe nervous about the investment that's necessary to get it off the ground. What do you think are the reasons why UMass has been able to do this so quickly and so effectively? Is it cultural, organizational, financial? How have you made this happen?
Oh, it's such a fun question, Chris. Candy, do you want to take a first shot and then I'll take a second shot?
Absolutely. I think, Chris, the fact that the system CEO, Dr. Dixon, who is an emergency physician by background, still spends a few hours every month in one of the emergency departments. I think, his belief in this program, the fact that he took a risk and set up a field hospital, proved that you can absolutely do this. So I think he was quite committed from the very beginning to making sure that we were able to, care for patients in an alternate setting. So, I think from day one, he just said, I'd like to see us do a hospital home program. There's a waiver available. A team was pulled together and off we went.
Couldn't agree more. And, I think in addition to the CEO alignment and there's a strong view that this is a strategic investment for the system. This is not a pilot. This is care for the long run and the long term with a vision around scaling and growing and bringing more patients to the home. And that's in the setting of a health system that provides high acuity tertiary care as a safety net facility to the entire region, and really needs to be able to build flexible capacity. And so I think those three things, the alignment, the team, and the burning platform, really all came together in the setting of the COVID pandemic and the waiver, with a really strong foundation. There's several folks who Candy and I are standing on their shoulders based on all the hard work that came out of the DCU Field Hospital. So we get to be here and having a thoughtful conversation with you, Chris, and your lovely team. But frankly, there's a lot of folks who did a lot of hard work before us.
When you talk about the team, Taki and Candy, how do you think about how that team should be assembled? You know, is it different to the inpatient care team? What kind of qualities do you look for when building that team?
Oh, I love that question. Maybe Candy, I'll start with a high-level view, and then I'd love to hear your view on our team, which it's sort of hard to overstate how good they are. You know, at a high level, Chris, to some degree, I think nobody is perfect for home hospital care. Everybody has strengths and weaknesses, and so what you need to do is pull a team together that addresses those strengths and weaknesses. So, for instance, on the physician side, we have home hospitalists who are geriatricians who are very comfortable with home-based care, geriatrics. They're used to taking care of very sick patients in skilled nursing facilities, but maybe they're a year or two away from their acute inpatient hospital medicine. And then on the flip side, we have hospitalists who are very comfortable with high acuity inpatient level care, but they don't care for patients in the home. And perhaps they're not as used to the geriatric sort of risk tolerance and risk management in the home and sort of gray zones. And so I think if you bring folks who have skills from both sides together, and I think this is where it'd be fun to hear, Candy, your view on this. If you bring those folks together, and the most important thing is they have an attitude around creativity and getting things done for the patient. And I think our team has an amazing attitude around, we will do anything for the patient and family. We will figure out anything. That above and beyond is really what matters. Candy, I'd love to hear your view.
Oh, Taki, I couldn't agree with you more. Chris, we did build the team from scratch. Remember, this is a brand new program, and the positions were created and posted. We've started predominantly with quite skilled emergency department nurses. I actually was a bit surprised. I thought we'd get a few more applications from our inpatient colleagues. And I think as word of mouth goes out, I'm hopeful that we'll see some additional applications come in from the inpatient side. But we're really very fortunate that we have, incredibly skilled emergency department nurses that bring, a lot of amazing critical thinking skills. They're very comfortable setting up a quick rapport with patients and their family. That's, kind of what they've done for years. But to a person, they'll tell you that this is their first opportunity to give true nursing care that they were taught to give in school, because it's the most amazing holistic approach to care. So they, every day I say, are you still loving it? And they do. I will tell you though, we learned very early on the value of a case manager. We actually held off filling that position, I think because we bring that ED background, and although we work with case managers every day, we didn't fully appreciate the important role they play in this program. But you can't do it without a case manager. There are so many pieces in terms of knowing what agencies are out there, what elder services, for example, might provide, some other agencies to be able to get them financial, legal, hospice help, and the case manager brings that important piece to the puzzle. And just an incredible add because we had to figure out every day how to get those things done. But when we brought our case manager in, she knew just exactly how to reach out and get a lot of those services much quicker than we did.
Candy, you talked about the virtual ward round. Are there specific, you've got a complex team and it's distributed, you've got patients who are out over a geographic area. Are there specific meetings and, events that you've had to organize with the team to keep them together? You know, things like the ward round and huddles and stuff like that. And what would you advise new programs to stand up and do?
I think one of the most important things is to have, you have to have a great program manager who, you know, pulls together all of the various tasks that need to be completed and keeps the team on task. But I think personally, one of the most important things that you can bring is someone on the team who has some experience in hospital at home. We're incredibly fortunate that Taki joined our team because he has started several other programs. Without his knowledge, we would be struggling through many of these issues. But almost every day, what would Taki do? What would Taki do? Or what has Taki done in the past? His expertise just makes things so much easier for us as we problem solve through some of the daily issues. Little things about, we deliver meals to the home, we deliver medications to home. Just talking through how other programs have done this. I also think the hospital home user group is a really valuable tool. There are some amazing videos on that website that I think very early on, I watched all of those, which gave me a really good sense for what exactly hospital home is and what kind of things you have to make sure that you have in place in order to get your program off the ground.
First of all, Candy, that is far too kind. So thank you for saying that, although it's completely untrue. I think there's some very pragmatic things that happen in hospital home that tend to be a lot more oriented around team building and just fun. And so one of the things I struggled with in brick and mortar as a hospitalist was that you often don't get to know individual nurses or individual speech language pathologists or individual paramedics. People are rotating through too fast. And I think one of the things that's a ton of fun is we have a mission control. We have a group of nurses and docs who come together every day, and it's a small team. We've got 6 or 7 hospitalists. We've got a similar number of nurses. We've got a slightly smaller number of paramedics, and so we get to know each other really well. We work together all the time. We all have strengths and weaknesses. We're all teaching each other things, and so it's just very rewarding. I think very pragmatically. I also will say, from a very pragmatic lens, all of our hospitalists are virtual, but early on in their training, they spend time in mission control, getting to know the team. And then our nurses, we have a combination of in-home and clinical coordinating nursing roles. And I'll certainly let Candy talk more in depth. I will say that the glue for the team is our clinical coordinator nursing role. And so this is, imagine it sort of like an eye in the sky, sort of a 30,000 or 20,000 foot lens view of what's happening in our virtual hospital. So for instance, if we have 8 to 10 patients, which we're increasingly having over the last couple of weeks on service, there's a lot of logistics and resource movement and allocation to take care of, oh, this patient's a little sicker, we need to do this. Oh, this patient needs this. And so we have clinical coordinating nurses who sit in our mission control. Once in a while, they swing out into the field to support our bedside nurses, but they're really sort of the eye in the sky, and they know more about the docs and the nurses and the patients than anybody else in our whole mission control. Without them, we would be lost. Candy, I'd love to hear your view.
I couldn't agree more, Taki. That clinical coordinator role is your air traffic controller. So as Taki said, they oversee every portion. They run the multidisciplinary rounds in the morning. Then throughout the day, they're constantly reprioritizing, coordinating care. We've learned very early on that when you have staff that are traveling, it's hard to engage them from a text messaging standpoint, from a safety, we want to try and keep them safe as they're driving. We found that they're often pulling off to the side of the road because they weren't sure if they needed to be on secure chats so that's part of our PDSA that we do every day. But that one individual here, because you have to have somebody who's screening for new admissions. That one individual here is kind of directing the case manager, directing the care, making sure the DME arrives. That is an incredibly important role. We're really fortunate because this team has actually worked together in the emergency department in the past. Many of them were, resource and flow nurses, again, air traffic controllers, for a football field side department. So this, I think, was relatively easy for them because they're used to directing things that they can't always see. But because the nuance here is the fact that it's services that they've never had to arrange in the past. So every day they're learning, and we work on our efficiency every day. But they are incredibly important to the success of the program.
Can you maybe share a bit about patient inclusion criteria? One of the things that I think we get asked a lot is what type of patient should be enrolled, and then how do you actually drive volume? How do you get those patients enrolled into the program? Because it's one thing to say this is who we're taking, and it's another thing to then get volume. Can you talk a bit about how you've defined your inclusion criteria?
Oh, yes, I love that question. And there's multiple levels to this. And I think the most important level I'd like to start with is an equity level and discussion. And then I'd love to talk about sort of our criteria, and I think also just risk tolerance and how you manage risk tolerance, because that's very, very important. So let me start with the easiest things, and I'll leave the hardest things to Candy, which is always a fun approach. From an equity lens, there are a lot of misconceptions about home hospital as a care model for folks who are perhaps wealthier and live in large homes and perhaps of a certain race and ethnicity. And I can't share enough how inaccurate that is. In our UMass Memorial Home Health Program, we care for about 35 to 40% of our patients in our program have Medicaid, so health insurance for low-income populations. We will go into all variety of homes. We've cared for a gentleman who lived in a wig shop, single room occupancy homes, and to shared informal living arrangements. With the Current Health colleagues and platform, we're using your wireless technology so they don't have to have internet. We're feeding them, we're bringing them food. The tablets have languages on them, so we're speaking their language. Many of our patients don't speak English. Many of them are sort of underserved, social determinants challenged populations. And there's actually some data to suggest that when you care for those populations, they disproportionately benefit from home hospital versus non-Medicaid populations. And so I think that's just one piece about patient inclusion that I want to be very strongly oriented around. But I think there's also some very pragmatic things, which is what types of patients are you caring for, and risk tolerance. And so, Candy, let you talk about the inclusion exclusion. And I think it'd be fun to also talk about sort of a holistic view of risk tolerance.
Thank you, Taki. In a nutshell, we try to take care of anyone who comes our way that has a home and electricity for us to take care of them in. As Taki mentioned, language is, not a barrier to us. And with our Current Health device, our patients don't even need an internet. We actually bring that into their home. So we just try to be as inclusive as we possibly can. That initial safety evaluation that we do is incredibly important, but we're finding on a regular basis that patients may appear really well put together, and they'll tell you they have food, and they'll tell you that they have a weatherproof home or room that they're living in. And when we get there, we actually find something very different. So those social determinants of health, and then those in-home visits to make sure we can shore up some of the issues that we find. For example, a CHF patient who's had frequent hospitalizations tells you that they have plenty of food, but when you get in the home, it's all takeout containers, which is not the healthiest diet for heart failure patients to be on. So we spend a tremendous amount of time doing education, whether it's dietary education, home safety education, medication reconciliation is incredibly important to us. You'd be quite surprised to find how many patients, can hand you a list of the medicines that they're on. But when you get in the home, half of those prescriptions may not be filled. There may be multiple doses of the same medications. We've had a patient who was just so confused, he just gave up taking any medicine at all, which of course, is how we met him when he presented to the emergency department. So we just spend an extraordinary amount of time making sure that we're shoring up our patients' environment, doing the best to add whatever services they need to keep them safe going forward, making sure that there is a PCP involved. And we like to think that when our patients go back to the PCP, we've painted a much more robust picture of what their real environment is, so that their primary care team can take much better care of them, because we've given them a whole picture of their living conditions, the kind of supports that they need, their family involvement. It's fascinating what you can learn in a home and bring together.
And at a very pragmatic level, to Candy's point, in addition to, we obviously need to make sure they have a home, running water and electricity, but we essentially bring everything else. What we've tried to do as a team is say to ourselves, what services does this patient you're looking at need? And can you meet their need and provide standard of care, and frankly, better than standard of care? And so we look through the orders and we say, can you execute all of these orders that are in the inpatient setting? And if the answer is yes, and there's not an MRI pending or a CT pending that they need urgently, that's often a very appropriate candidate. And one of my jobs and Candy's jobs, and we talk about this all the time as a leadership team, is to find the right risk tolerance for a program. Because remember, we're caring for patients who have a lot of concerning safety events in brick and mortar facilities. They typically are older, they often have social determinant challenges, they're very high risk of falls, infections, DVTs, loss of function, transfer to skilled nursing facilities. And so you have to sort of, as a team, say to yourself, this patient is on oxygen and is pretty sick, but guess what? We can provide high acuity inpatient level care. And so what typically happens is that there's a first 10 to 20 patients of sort of courage building. And then once you get past that first 10 to 20 patients of courage building, the courage is there and you realize that the patients do amazing, and then you're kind of off to the races. And so that's the really vulnerable part, is the first month.
I think probably talking one of the best examples, we took just a delightful woman home, and her daughter tried to tell us she had some challenges at home, but it turns out she had a significant issue around hoarding. And so when our team first walked in, the ceiling was in disrepair. There was just literally stuff everywhere. And the first inclination, the nurse FaceTimed me and was, kind of showing me the home. And I was like, oh no, I don't know that we can do this. But, after you take a deep breath and step back, we huddled together via conference and decided, what risk we could take. They were able to clean a path to her, get her safely to her bathroom. She certainly had running water. We got her food in her home, and we took amazing care of her. And I think, to Taki's point, that risk, you start out very conservatively because, to be honest with you, none of us have done this before. Taki has, but the nursing team hadn't. We are so much better at that now, that it's really about, let's just get them home and take amazing care of them. So it's so true that your risk tolerance does go up. And, some days, when we realize the wig shop, did we make the right decision? But guess what? We took great care of that gentleman. And every day we just make it work.
One of the things I thought, and you've both touched on patient safety, but I think a nervousness that we've seen in clinicians, medics, nurses is the patient as safe at home as they are when they're 10 feet from the nursing station. And I guess your statistics on this speak for themselves. But I guess what's your message to those nurses and doctors who are nervous about that patient and being safe in their own home when they can't, just walk 20 paces and put their hands on them?
I think it's a combination of technology and humanity, those two things together. So, you have to trust the technology, and we certainly trust our current health technology to be able to monitor the patient. So if you don't believe in the technology and then the humanity doesn't come behind the technology. So you have to believe that the data is going to be there, that you can trust the data, which we do. And then you also have to believe that you can get to the home and respond in time. And that's a little bit more of a humanity element. And so, but once you see that enough, once you see the data, you see the experiences, you see the sort of the response times, you start to realize that you can actually dial up and take sicker patients over time. And I think that's what we've experienced. So what's a little bit different is that, the combination of, in the old days, you stuck your head out of the nursing station or the doc station and you looked at the patient through the window. We still can do that. We have a tablet in the home and we can push that button and you can see the patient through the window. And to Candy's point earlier, you pull up the app and you look at their vital signs on the phone or on their computer if you're at a computer. And so it's just a slightly different version of the same thing.
I guess to just coming on to the last couple of questions, this whole model, the acute care at home model, from a regulatory and payer perspective, as you touched on, Taki, is incredibly new. What regulatory and payer changes would you like to see going forward around this model, maybe both in Medicare and Medicaid, but also in the commercial space as well?
Oh, definitely. Chris, thank you for asking that question. So in the pre-waiver era, it was mostly commercial and Medicare Advantage plans that were compensating and reimbursing for home hospital care, which had enormous equity challenges. You had the entire Medicare fee-for-service and Medicaid population that didn't have access to the safe and effective care model. The waiver knew that November 2020 comes along, that changes everything. We're now able to distribute the safe and effective care model more equitably. And now what we're asking of Congress, and we've had conversations with our own congressmen and senators in Massachusetts, with the Ways and Means Committee, many folks are very, very much on board. And so what we've asked from our regulatory colleagues and from our payer colleagues, and really mostly this is around CMS. And so what we've heard from our colleagues essentially is that there has to be statutory changes to extend the CMS waiver beyond the end of the federal public health emergency. And so that's our number one desire from a CMS perspective, is let us keep taking high acuity inpatient level care safe and effectively for our vulnerable patient populations. Let us keep doing that. And I think the second ask beyond that would be, and let us also admit patients from the home, because we've got vulnerable patients that are in the home. And right now the CMS waiver does not allow us to admit them from the home. We know those patients going to the emergency department don't do well in the emergency department. We know they do better in the home. So I think those are our first two real asks of our colleagues in Congress. They've been very, very receptive. Congress has obviously got a lot on their plate. And so it's just a matter of advocacy and time. Candy, would you add anything to that?
No, I think your point about admitting from home, even from clinic, would be incredibly valuable. Right now, the CMS waiver requires the patient to touch the emergency department. So we have had some folks reach out to us who've seen, are actively seeing a patient in clinic, and sadly, we're not able to accept that patient. So it would be wonderful for that to, for us to be able to just take a patient from wherever they are, as long as they're appropriate for our service.
Couldn't agree more.
I think it's not often in healthcare where you get something where you can improve clinical outcomes, you can make the patients even safer, and you can actually do it at lower cost. And healthcare and providers, I think, get a reputation for being slow moving and conservative. And it's remarkable that when this acute care at home model has come along, look how quickly organizations like yours have stood up and run these incredibly innovative programs that are creating better outcomes and doing so sustainably. So there's just so few opportunities like that to see that actually happen. I think it's truly incredible. I wonder if we could maybe finish by just asking you both to share, I guess, your biggest piece of advice to anyone else who's out there in the US who's considering standing up a program like this.
Well, I'll go first, Tati. I think, Chris, the most important thing is as I said, putting together a really solid project plan. There are so many pieces of this program that may not be as evident on the surface. You have to set up a brand new budget. You have to invest in technology. You have to have vehicles to get your staff around the various places. You have to have a relationship with a DME program, an MIH program to support you, 911, stuff to keep, equipment to keep your staff safe, which, now with our time change and, it's darker much earlier in the streets of Worcester. I worry every day about keeping them safe. So little things like getting them a flashlight, buying them a whistle, just little things to make sure that they're safe. So there are a lot of elements that go into building this program, but with a solid project plan, and you're just ticking those off. The IES portion, I can't understate that enough. You have to have that technology piece, not only on our current health side, but just that whole integration to the medical record. And then an incredible team who every day wants to just take the most amazing care of patients.
I love that perspective, Candy. And I think the only thing I would add is I think it's partially around alignment, around team building, and around a passion for doing something really hard for patients in the home in a way that delivers value for the patient, the family, the system, the providers, the nurses, from a sort of joy of work perspective. And so, on some level, the two of us have maybe simplified it more than we should have. It is complex, it is hard, but I think with those things together, it can be a ton of fun and just incredibly rewarding.
Well, thank you for that. And I just want to say a massive thank you to you both for taking the time out of your busy schedules to come and share your expertise with everyone. Honestly, genuinely watching the program you've built, it's been a real privilege to partner with you on it, and really inspirational to watch what you have all done and built. So thank you for being incredible partners. Thank you for coming and sharing your expertise today, and to everyone else, I hope this was valuable, and I hope you all have a wonderful rest of your day. Thank you.
Totally. A huge thank you, Chris. I think we feel the
Chris.
exact same way. It takes a village, and this wouldn't be possible without you and your team. So a huge thank you.
Absolutely.